at last. My name is Candy Birch, and I am here to get this caucus started with a few remarks. I have been in favor of universal health care for some time now. I wasn't really sure how it would work, but I definitely believe that everyone should have access to health care. Then 2 years ago, I attended National Convention virtually, like many of you may have done. And I watched a presentation by this very group, the Healthcare Reform for the United States. Here were distinguished league members, all experienced, all very knowledgeable, like so many league members are, actively engaging and advocating and organizing to make healthcare for everyone in the United States a reality, including for my kids and my grandchildren. So I became inspired to work more seriously and more persistently for healthcare for all. So here I am, confident that you will be as convinced as I was 2 years ago that affordable and accessible and equitable health care is not only in the public interest, it's a necessity. And we hope to convince you that fundamental health care reform is actually a realistic and achievable goal. Thank you so much for giving us the next several minutes to present our case to you. You will be impressed with the information from our young medical students. Once they have presented their cases, we will be happy to entertain your questions. If you're there in the room in Denver, you'll find papers on which to submit your questions. If you are joining us online, please put your questions in the chat. Members of our caucus will curate those questions, but rest assured that if you don't get your question answered, we will respond after the presentation. So let's begin. I don't know about you, but I am thrilled to hand over this program to two third-year medical students and league members, I might add. It did not take them as long as it took me to realize how important healthcare is for all. Simran Arya attends Stony Brook Renaissance School of Medicine in New York. She looks forward to using her degree to improve health outcomes for all at both the patient and the policy level. Joey Ballard attends Indiana University School of Medicine, and as president of his school's SNAP chapter, he has worked with the parent organization Physicians for a National Health Program on single-payer advocacy. He tells us that he is honored to speak with the League of Women Voters. But truthfully, we are honored that these young people have joined us to discuss their keen awareness that our healthcare system affects us all. I think it's safe to say that the decision of the Supreme Court yesterday will bring into even sharper focus that healthcare in the United States is now and will continue to be in crisis. Now more than ever, we desperately need quality healthcare that is equitable and affordable for everyone. Our healthcare system needs an overhaul. Simran?
Is this on? Is it working? It's on. Okay. Thanks so much, Candy. I just wanted to reiterate that I am the one who's honored to be here and so happy to be spending time with you all and talking a little bit about crises in healthcare. So when I think about everything wrong with the United States healthcare system, I get a little bit overwhelmed because there's a lot, unfortunately. But it helps me to think about it in three key pieces. That's going to be high costs for poor quality, limited affordability, and inequity. So let's get started. High costs and poor outcomes. This is a map of the total national health expenditure as a percent of GDP, starting from 1970 and going up to 2020. So in 1970, about 7% of the GDP was going towards healthcare. Over 50 years, that number nearly tripled to 19.7%, so huge increase. This is a graph that shows a similar point. It displays family health insurance premiums as a percentage of median income over a shorter period of time, 1999 to 2016. So you can see in 1999, about 14% of the median income was going towards family health insurance premiums. But by 2016, that number had more than doubled to above 30%. And I think it's important to note here that that kind of spending is unsustainable because you have to pay for more things than just health insurance, right? You have a house, you have clothes, you probably have kids that you have to take care of, food, everything else that goes into quality of life has to fit into this budget. And it's just really not sustainable. And I want to also highlight here that United States healthcare spending is an outlier. It is true that many comparable nations have increased their healthcare spending over time, but the United States is the top line on this graph, and you can see that it goes far above all the others. So while everybody's healthcare spending has increased over the last 40 years, the United States has increased far more. So what do we get for all this extra resources that we're putting into healthcare? This slide kind of spoils it, but we get poorer outcomes. So this is life expectancy at birth in years from 1980 to 2020. And yes, life expectancy has increased in both comparable countries and the United States, but you can see that we lag far behind people who are comparable to us. And in 2020, both lines saw a dip due to the pandemic, but it's really telling here how much steeper the slope is for the United States in comparison to the country average. United States adults also have the highest chronic disease burden. So chronic diseases are going to be your conditions like diabetes, hypertension, things that are going to follow an individual for a very long time and need to be adequately managed. And the 11-country average that we're comparing to was 17.5% of individuals had at least one of these conditions. But in the United States, we're 10 percentage points above the average at 28%. And finally, maternal mortality. This is a really important indicator of how well a healthcare system is doing. And this shows maternal mortality in selected countries in 2018. And you can see that the United States has a maternal mortality of 17.4 per 100,000 births, which is exactly double the next lowest, which is France at 8.7. I want to highlight two things here. One, that this data is from 2018. Newer data puts the United States maternal mortality rate at around 23.8%, or per 100,000 live births, which is bananas. And all of these other bars have decreased in that time. The United States bar has increased. So that was the first point I wanted to make. The second is that in light of the Supreme Court's decision that came out just yesterday, I think that we're going to see even more telling trends in the coming years. So in sum, we get poor outcomes for higher costs. Where is the money going? We're putting all this money in, but we're not getting any better healthcare outcomes, so the equation is imbalanced. Where is it going? So many people like to say administrative spending, and the estimates have a large range. They go from 15% to 34.2%, and it kind of depends on who you're asking and what they're counting. Everybody counts actuarial services and underwriting. This is the money that the insurance companies put towards coming up with the insurance plans that are going to make sure that they are able to stay afloat. That makes sense. A lot of people also include marketing. So this is going to be the ads that you see in the newspaper or on TV telling you about a certain insurance company. But there's also the marketing that insurance companies do to employers to say, hey, you're a big company, you should use our insurance services to cover your employees as opposed to this other insurance service. That's a big amount of resources and money going towards that endeavor. Additionally, human resources. It makes sense that we would count the insurance company side of this, the human resources it takes to run that company. But what about the human resources it takes to run employers and all the resources they put towards organizing plans for the people who work for them? And finally, prior authorizations and denials. Again, it makes sense to count the insurance side of this, the resources they put towards denying claims that wouldn't be profitable for them. But there's also a significant amount of work and resources that goes into handling prior authorizations from the provider end. I used to work in a hospital before coming to medical school, and there was an entire department of people whose sole job it was to deal with prior authorizations to make sure patients could get the care that they needed. So what does this add up to? It adds to limited affordability. This is an insurance bill. It gives me a lot of anxiety. I think my blood pressure goes up every time I look at this slide, and I'm sure I'm not the only one. Healthcare costs a lot. And it shows in the numbers that these high costs prevent people from accessing or getting the care that they need. 30% of Americans report not seeking treatment for a health problem due to cost. 11% of Americans report borrowing money to pay for care. And 12.7 million Americans report knowing a loved one who died after foregoing treatment due to cost. As a medical student, I see a lot of this, unfortunately. I'm the person who's in the room after the attending and the residents leave, who's left to help out the patient with whatever random things that weren't addressed by the doctor. And so much of it is, how am I gonna pay for this? I had a lady who was adamant about leaving the hospital after she had a subarachnoid hemorrhage, which is when a part of your brain is bleeding. And she said, I have to go home. And I said, you have blood in your brain, you can't go home. She had just gotten off the phone with insurance that morning, and they said they weren't gonna cover any more days. That's why she was anxious to get out of there. And I just like to include this slide to drive home the point that in a country as resource-rich as ours, we still have people coming up with GoFundMe pages to get enough money to pay for the care that they really need. Care that's accessible, and it's here, and it's there for the taking, but just not affordable. Inequity. So all of these issues that I've spoken about influence certain groups of people more significantly than others. This slide demonstrates how those of lower income are more negatively affected by the problems with our healthcare systems than those of higher income. So the darker colors are people who are less than 200% of the federal poverty level, so they make less money. And the lighter colors are those who are greater than 400% of the federal poverty level, so those who make more money. And you can see that those of lower socioeconomic status are more likely to not have a usual source of care, are more likely to delay getting care, are more likely to not afford prescriptions, are more likely to have problems paying medical bills, and are more likely to be dissatisfied with care. So a clear correlation there. Race is also a huge factor, and I think it's also really important to talk about the COVID-19 pandemic in any discussion about issues in the United States healthcare system, because this was a big event that really uncovered a lot of huge problems that we have. And you can see that there was a huge degree of difference of hospitalization rate and death rate depending on race. White people were less likely to be hospitalized and die from COVID-19 than their Black, Hispanic, and Asian counterparts. And the people who had the biggest burden of the COVID-19 pandemic were Black and Hispanic individuals, as you can see from this graph. I like this graph because it displays the urban-rural healthcare divide, which is really important and not something that gets as much attention, unfortunately. So on the left side is where you want to be, associated with better healthcare outcomes, and on the right side is where you don't want to be, associated with worse healthcare outcomes. The U in the orange circle represents urban areas. And from the top of the graph, we can see that urban areas have more primary care physicians per capita than people in their rural counterparts. And from the bottom of the graph, we can see that there's a similar trend for dentists. There's just more of them around in urban areas. And it makes sense that this kind of adds up to the graph we see in the middle, preventable hospital stays per 100,000 Medicare enrollees. In urban areas, there's less preventable hospital stays, while in rural areas, there's more. And it makes sense, right? If you have somebody that you can go to for your general care, you're more likely to see a doctor before your problem gets out of hand and requires a hospital stay. So a concrete example, if you have a general practitioner who you can go to for your diabetes management, you're more likely to get your blood sugar under control before you end up in the hospital in hyperglycemic crisis. So other factors in access, we talked about urban-rural divide, so simply just not being a lack of providers, but there's also the issue of transportation. How do you physically get to your provider if you're in a rural area and you don't have a way to get there? And language and cultural barriers. What if you don't speak the same language that your doctor speaks? What is getting lost in translation? Or what if there are cultural barriers that are preventing you from going to the doctor and seeking the care that you need? And again, I think that the United States Supreme Court decision is really upfront here. This map shows in dark areas, this graph shows that your distance to an abortion clinic, and the darker areas are associated with greater distance. So you can see that some people are going to have to be getting over many more significant hurdles in order to, again, get the care that they need. So that was everything, or a lot of things wrong with the United States healthcare system, not everything. But I wanted to hand it over to Joey now to talk about some potential solutions. Thank you.
Okay, thank you, Simran. My name's Joey, and I want to talk to you all today about these crises and the solution to them. But first, I want to acknowledge the Supreme Court's decision yesterday. I haven't been able to stop thinking about it, and at times I'm at a loss for words. I imagine that's the case for most of you too. It feels that this is the most pressing crisis, and I wish we had more time to present on it. At the same time, we still have the systemic issues we're presenting on today, which are worth discussing. You may notice that I'm wearing scrubs. I just came from a shift at a student-run free clinic in Indianapolis. For many patients, we provide their only interaction they have with the healthcare system. Some patients are without healthcare access because of the cost, others because of loopholes that allow their employers to not provide it, and another group because of their citizenship status. And despite our society's failure to figure out how to get them comprehensive care, their medical conditions affect them nonetheless. This isn't the kind of system I want to practice in and shouldn't be the one we have to settle for. So let's talk about what we can do to change it. Next slide. Simran did a great job of explaining the crises we're facing concerning quality, equity, and affordability. And it's understandable to feel overwhelmed, but I'm here to say that we can do something about them. Next slide. Let's consider how we got to these crises. You may be wondering about the free market and even think that is the solution. So let's talk about it. Our healthcare system doesn't follow ideal conditions for the free market. I've listed a few principles, including having many sellers, having buyers with perfect knowledge of the product, and having the choice to buy. Healthcare is essential to live, making this a coercive setup that is contrary to a true free market where buyers can decline the transaction if they want. Another clear example of this concept in medicine is with insulin and other life-saving medications, which have inelastic demand. People need insulin to survive, so demand doesn't change regardless of the price. This creates a captive audience of patients subjected to our for-profit healthcare system. Furthermore, free market forces are incompatible with healthcare delivery. In this context, demand is contingent on ability to pay, but not objective medical need. Resources are shifted away from people who need them most. With for-profit insurance companies, free market forces drive risk avoidance, resulting in cherry-picking the healthiest, most profitable patients while limit dropping the sickest, least profitable ones. Fundamentally, these companies profit by withholding payments for services, which is easiest to do with a healthy group of people. Lastly, free market forces have a demonstrated track record of their inability to control healthcare spending in the United States. I will discuss how having multiple insurance companies actually drives costs up instead of lowering them by competition, as you may assume. Next slide. Next, I want to talk to you about healthcare as a public good. Public goods are commodities or services made available to benefit all members of society, typically administered by the government and paid for by collective taxation. People need them, making them examples where the free market is inapplicable because they can't decline the transaction. Some examples include law enforcement, national defense, and access to clean air and drinking water. Individual nations decide on what goods and services they prioritize as public goods. Public goods' economic and social benefits significantly outweigh the cost. Many countries prioritize healthcare as a public good. The United States' position views health at the population level as a public good, as public health efforts are financed by taxation, but individual access to healthcare isn't. Failing to prioritize healthcare as a public good leads to the deaths of 45,000 Americans annually. They pay the price for a system that fails them. In addition to the moral imperative, I hope to show you that healthcare should be a public good in part because of its substantial economic benefit. Next slide. I want to direct you to the League of Women Voters' existing healthcare position, which has the solution to address the crises and make healthcare a public good. As you know, the League is nonpartisan, and its position is based on studies, making it more credible. The position states that a person's ability to pay shouldn't affect the allocation of resources, corresponding to quality. It says that healthcare should be afforded to all US residents, which is an important term that applies to citizens and non-citizens alike, which addresses equity and access. Lastly, it explicitly mentions affordability, efficient economical delivery, and cost control strategies. Notably, the League of Women Voters supports a, quote, single-payer approach. So let's talk about what that means. Next slide. Simply put, a single-payer healthcare system is defined by one entity, usually the government, financing all healthcare payments. This is in contrast with our extremely fragmented system with many payers. That is the most simple defining feature, but there are many different ways to implement such a program. For example, some refer to the United Kingdom's single-payer system as, quote, socialized medicine, because it's paid for and delivered by the government. The type of single-payer system proposed in the United States isn't considered socialized medicine because it would still be delivered by private entities, just publicly financed. This program would be funded by a progressive tax plan. You may be concerned to hear about more taxes, but 95% of households would pay less than what they are currently spending on healthcare, with only the top 5% of households paying more. The implementation of this program, according to the current proposed legislation in Congress, would eliminate copays, deductibles, and premiums, and provide comprehensive cost control mechanisms that I will discuss next. Next slide. The first and most important source of savings is the massive decrease in administrative costs. Our current system has numerous private health insurance companies, each with its own rules, regulations, and formularies that require experts to navigate. Their very existence requires hospitals to have massive billing and administrative departments in order to interact with them, driving up costs. This complexity is unnecessary because these companies fill the same role and show why having more insurance companies drives prices up instead of lowering them through competition under the free market. Having a single-payer system to eliminate this redundancy would save our healthcare system an estimated $500 billion annually. Additionally, covering all US residents would provide a powerful negotiating position, freeing us from being held hostage by Big Pharma and contributing to an additional $100 billion in annual savings. There are other areas that a single-payer system would add to savings and contribute to cost control, but these two are the most significant. Next slide. You may recognize this slide from earlier, and I wanted to return to the idea of existing track records. Single-payer has a demonstrated record of success in other OECD nations, as they have not had such experienced such drastic rises in national healthcare expenditures compared to the United States. So we know this works. Next slide. Next, I want to talk about hospital budgeting. Currently, our profit-oriented healthcare system strains rural hospitals and contributes to the disparities that Simran covered earlier. Hospitals are paid for on a fee-for-service basis. Rural hospitals have a lower volume of patients, but need to maintain proper equipment, facilities, and staff. They also have more patients who are uninsured and a larger percentage that have Medicaid or Medicare, which reimburses less than private insurance companies. making it harder to cover costs and not run a deficit. As a result, there have been 136 rural hospital closures since 2010, which contributes to rural health disparities and brings a devastating economic impact to those communities. Global budgeting under a single-payer system views hospitals as part of the healthcare infrastructure, and their operating costs would be covered to provide financial stability. This would eliminate the uncertainty that rural hospitals face disproportionately. Furthermore, the Congressional Budget Office, which provides nonpartisan and impartial economic analyses of federal economic and budgetary decisions, estimates that a single-payer healthcare system would save state governments over $800 billion by 2030, freeing more funds to address other areas. Both global budgeting benefiting rural hospitals and less pressure on state budgets are appeals that can be used in more conservative areas to show the benefits of single-payer. Next slide. Throughout my presentation, I've used the term single-payer as opposed to Medicare for all. It is important to note that a true single-payer solution is an expanded and improved version of Medicare as we know it today. People who oppose single-payer may point to issues with the existing Medicare program as evidence for why single-payer wouldn't work, but they often ignore the expand and improve language. I want to clarify what that would mean. And it includes coverage being expanded to all US residents with an improved Medicare program having the ability to negotiate prescription drug prices and coverage for the following services: primary care, vision, dental, hearing, prescription drugs, mental health, including substance use disorders, long-term services and supports, and reproductive health care. I know it may seem hard to believe, but we would still be saving money with a single-payer system with covering all US residents with all of these services. Next slide. Let's revisit how single-payer addresses the three crises. Overall quality would be improved with expanded access, more services covered, and the elimination of cost sharing, which is known to be a barrier in obtaining care. In terms of equity, this coverage would reach all US residents. With affordability, we've spoken about the massive decrease in administrative and prescription drug costs, and single payers demonstrated success in other countries. Next slide. Now that we've talked about single payer as a solution, what can we do? First, I want to mention the existing federal legislation that seeks to establish a single payer healthcare system. As you can see by the co-sponsored numbers, there's a long way to go before this will be enacted. At the same time, we can take pride in the fact that this is the most support it's ever had in Congress. This is major systemic and societal change, which requires patience and persistence. It's also helpful to contextualize this with its immense support among the general public and even now among physicians. Next slide. Health is essential for a healthy democracy and vice versa. A healthy democracy can affect the change that the public wants to see, which is a single payer system in this case. If you're motivated to take action on supporting single payer, resolution writing is a powerful way to continue to build momentum. This can be done at the town, county, and state levels. I've attached resources